Welcome back to the Curbsiders. I'm Dr. Matthew Watto, here with my great friend, Dr. Paul Nelson Williams, who I should mention is America's primary care physician. Paul, how are you doing tonight?
I think it's taken off, Matt. I'm doing great. How are you doing?
Well, I'm doing great because we're going to talk about COPD in older adults. We had two great guests on this episode, which was number 408, if people are looking for the podcast after this. And Paul, what we learned about is that as people get older, their lungs get older as well. And on balance, what that does, it makes it so that the thoracic cage has some changes. There's less elastic recoil, and the respiratory muscles just don't work as well. So in most people, that ends up looking like a more obstructive pattern if you were to get spirometry. But Paul, should that change? Does that mean that we can diagnose every older adult with COPD just because they have abnormal spirometry?
I feel like we probably shouldn't. Yeah, thanks for setting me up. Yeah, I think we get very tied up when the FEV1 to FVC less than 0.7 is sort of making the diagnosis, and once you're there, everything else kind of falls by the wayside. But I think it was Dr. Witt in particular on this episode talked about how symptoms you need symptoms consistent with the history, and then also exposure too. Matt, you actually asked a point about this COPD asthma overlap syndrome, and she talked about just getting a childhood history. So even when you're dealing with presumed COPD, a lot of the times it's one of those anecdotal diagnoses that kind of hangs on for forever without the diagnosis actually having been formally made. And so getting a good history, making sure you're doing your due diligence and just doing the basics can go a long way, make sure you're taking the right care of patients.
Yeah, absolutely. So it's the post bronchodilator FEV1 to FVC ratio less than 0.7, and we're still using that same one for older adults. You might slightly overdiagnose, but you got to look for that clinical history and the symptoms in order to make the diagnosis, as Paul said. And then when we're thinking about how we're going to treat them, you need to know which classification they fall into. So we used to use spirometry and go by the FEV1, but that was actually really poor in predicting like how much symptoms people are actually going to have or who's going to exacerbate. So there's this MMRC, which is a 4-question. It's actually kind of a grade. So you sort of pick which grade the person fits into, or you can give them this 8-question CAT score, and based on that, you can give a severity. The severity would be, low symptoms or high symptoms, and then you also figure out whether or not they've had an exacerbation, which would be they needed to be treated with like antibiotics or steroids, or if they've been hospitalized for COPD. And those patients that have been hospitalized or have been treated for an exacerbation are automatically in the E group, which is the exacerbation group. And those patients should jump right to a combination therapy when you're treating them. And Paul, which medications are we really pushing in COPD? Is it the inhaled steroids?
Not for most patients. There is a role for some, but that's a little bit more nuanced. But to start, when you're just kind of starting out, it seems like the LAMA is kind of a safe backbone of therapy. So for patients who have mild symptoms or who are not having a lot of exacerbations, you almost can't go wrong there. If someone is coming to you with a high frequency of exacerbations or pretty severe symptoms, then a LAMA-LABA combination makes a lot of sense. And our guest made the point, you can always de-escalate if you need to. So it's okay to change therapy after you start or kind of adjust if you need to. But the LAMAs as a very basic backbone seems fairly consistent throughout.
Absolutely. Yeah. And I love the point that she made that you can step up and step down therapy. And she even does a check-in. I think she said something like 6 to 8 weeks, start them on an inhaler, see if they get better. If they don't, maybe she'll step up therapy, see them back, and again in a certain time period. And if they're still not better, then maybe the combination isn't working either. And maybe you just go back and try something else. So I think that it's good to know that it can be fluid, because I think most people just get slapped on an inhaler, and then unless the formulary changes, there's nothing else gets changed.
Yeah, and I think she kept reiterating the point too. It's worth going back and making sure you have the right diagnosis. Like if you're sort of stacking on the therapies for COPD and the COPD is not improving, maybe that's not what you're deling with. So I thought that was a really helpful point just to keep in mind, because it's easy to keep pushing and going nowhere.
And Paul, these inhalers there's so many of them, and there's different devices, and they're all patented, and that's probably on purpose so that they can, remain expensive. So how can we navigate this, and how can we help patients? Is there a resource or an app maybe that maybe a foundation makes that people could point their patients towards?
say for patients with COPD, for instance. I believe
Yes.
there is a COPD Foundation videos specifically, and we talk about this in the episode. I think I'm just as guilty as anyone of not having full mastery of how to actually use inhalers, and which means I can't teach it effectively. So this episode in part has prompted me to look at the videos myself, even watch them with some patients, and just reinforce that the inhaler technique is you have to be able to know how to use the inhaler for it to actually be effective. So just going back and being sort of foundational again and making sure you get those basics right is going to be a way to help your patient the most in the long run.
Yeah, exactly. I mean, that's why on boards they always ask you like the right answer is almost always make sure they have a correct inhaler technique
Yeah.
because it is just so commonly not done correctly. And the app is really great because you can toggle between like a provider view and a patient view, and the videos are embedded right in there, so it's really great. Um, all right, in this episode, we went way into depth on COPD, so I would highly recommend people check it out. You can click on the link in the transcript below. And with all that, I should say this has been another episode of the Curbsiders, bringing you a little knowledge food for your brain hole.
Do you ever wonder what Rachel Ray is up to?
All right, until next time, I've been Dr. Matthew Frank Watto.
It wasn't supposed to be a rhetorical question, but I remain Dr. Paul Nelson Williams. Thank you and goodbye.